Uh, Please review the chat box. I have sent you the training feedback link. After completion the training, you have to give us a feedback. Your feedback is valuable for us. And thank you very much for joining us. So my name is Asif Iqbal. I'm a training manager consultant for Asian Snipe Diagnostics. Today we have a presentation on tumor markets overview, along with the total PSA and free PSA essays. So let's start with the tumor markers overview. So, as you know that the cancer is one of the leading cause of deaths globally, and it's the second leading cause of deaths in developed countries, and approximately 3 million deaths per year globally by carcinomas. So, according to the age estimation, standardization incidence, and the mortality rate globally, as per the WHO, International Agency for the Research on Cancer, in 2018, for both male and female and at all ages. This data source from the Globocan 2018, which shows that the incidence and the mortality globally is increased, and the highest rate of carcinoma is the breast cancers. The second number is the prostate, and then followed by the lungs, colorectum, cervix. Just give me one note. Uh, so prostate, lungs, colorectums, cervix, uterus, stomachs, livers, corpus uterus, thyroid, ovaries. So these are all the carcinomas, different types of carcinomas, and their prevalence, and their incidence, and their mortality globally existing in the world. So again, the major cause of these carcinomas, if we talk about the carcinomas, what are the major cause of these carcinomas? The number one major cause is inherited or maybe some acquired, is due to the gene mutation. The second major cause is proto-oncogenes. And in some cases, there is tumor suppressors genes are also the major cause of the carcinoma. So if you go to the, just So if we go to the cancer predictions according to the
также тяжелой
guidelines,
броней и щитами.
that's the
Если
tool
вы
that
играете на
can predict the future cancer incidences and the mortality burden globally in 2018 and in the up to the 2014. So according to that data, till 2018, 18.1 million cancer incidences are reported. So if you see here, so these are the cases which are reported globally, and 0.5 million carcinomas cases or incidences are reported in 2018. If we consider that ratio of prevalence and incidences reported for the carcinoma, we are expecting by 2040, 29.5 million cases will be reported globally till 2040. So this is a big challenge for future if the carcinoma incidences are increasing and the mortality is increases due to this prevalence of cancers on a different in the men and women in all ages is increasing day by day. So the next is about so if we talk about the prevention, so the best prevention about the if we talk about the prevention, then the most important thing is the early detection. As you know that if the carcinoma or a cancer early detections occurs, it will helps to treat better, because the carcinoma has a different stages, and the percentage of survival up to the 10 years is more if it detects at the early stages. Like according to the diagnosis and the stages of diagnosis, there are 10-year survival for the 8 types of cancers combined. But then if they detect at the stage of 1 and stage 2, the survival rate up to the 81%. If it's diagnosed in the late stage, like stage 3 and stage 4 or different carcinoma, the survival rate up to the 10 years is around 26%. So the different stages of cancers when diagnosed for the 8 cancers, and that's an early cases that diagnosed in between the 1996 to 2000 in the east of the London, England. So they covers the 8 different types of cancers, including uh, the bladders, the bowel, the breast, the cervical, the womb, then the malignant melanoma, ovarian, and the testicular carcinoma. And they have said that the early detections helps to have a survival rate 73% detections, and then in the 27%. So the 40% of all cases of cancers in the UK are accounts together. So this is the best way if you detect earlier. So the serological markers has a clinical more utilization in the detection of the carcinomas. So if you go to the next thing, that what are tumor markers? So you know that the tumor markers are basically the molecules that are produced by the cancer cells, and you know that the cancer cells are the abnormal growth of cells is called cancer cells, or that's the body response to the cancer cells. There are some benign condition in the non-cancerous condition in which there are some tumor markers are increased. So if we goes to the some terminologies like screening, diagnosis, evaluation, prediction, and the monitoring. So these are very specific and highly utilized terminology in the tumor markers or the cancer serological analysis. Like on the basis of epidemiological distribution, global distribution of different carcinoma, a healthy population or a high risk population, screening is required to probable presence of that cancer. So the screening test for the specific population for the specific carcinoma is called a screening test. The diagnosis on the basis of the clinical symptoms and the prevalence and the inherited feedback or a history of a patient, they have goes for the diagnosis for the cancer or a specific type of cancers, serological and imaging radiological testing to diagnose that disease on the basis of the clinical evidences. Evaluation, the prognosis in a patient. If the known patient is treated and then the treatment is going in the right direction or the prognosis occurs or not, that's called an evaluation in the prognosis. The predicting, it's also called a risk stratification. In such cases, if you have a patient which has a high risk population, so they can on the basis of the different carcinomas values, they can predict the potential of that patient to be a therapy or a potential risk of the predicting response of that therapy is also is under this terminology. The monitoring, if the patient is receiving therapy, either this invasive like in terms of surgical or in terms of non-invasive like a radiation or a chemotherapy or in some other medication, that the monitoring of that patient of these specific tumor markers are more essentials, because these tumor markers values increase or decrease during the treatment and after the treatment and for the screening and the diagnosis purpose. If we talk about the different tumor markers, so in a whole human body, there are different in the endocrine systems, they have a different hormones are released and the markers are released in the body. Like if we talk about the thyroid gland, which release along with the T3, T4, TSH, CA, and thyroglobulin as well. If you talk about the lungs also release carcinomic embryonic antigen and carcinomic embryonic antigen 125 Cypher 21-1. So these are the lung-specific tumor markers and generalized also the carcinoma markers. If you talk about the breast, CA, CA15-3, and the esophagus, CAG, CSS, these are belongs to the different organs and glands. If you talk about the livers and bile duct, they are releasing CA, alpha fetoprotein, CA19-9, along with the ovarian cancer's specific marker are CA125, CA72-4, even in some cases CA125, along with with the other markers are also helpful, like HE4 and other ovarian markers, highly specific. If we talk about the uterus area is also a CEA, CA125, and SCC are the highly specific tumor marker for that. If we talk about the metastasis to the bone, CEA and the colorectal, CEA, CA19-9, M2PK, and stomach pancreas like CEA, CA19-9, 72-4. These are the highly specific tumor markers in some cases and in some generalized cases to rule out some non-specific carcinoma condition, and then further radiological and the invasive procedure helps to rule out the tumor markers in such patients. So if we see that these are the recommendations or the organs that or glands that are involved in that. So what is the solution that SNIBE is providing from the Meglumi platforms? So we have the biggest menu for these all tumor markers, which include the conventional tumor marker with then a specialized tumor marker as well. So if we talk about the conventional marker like alpha fetoprotein, CEA, total PSA, 125, 15-3, 19-9. Along with that, we have a much further specialized markers like free PSA, CA242, CIFRA 21, PAP, CA50, NSC, S100, and the brain tumor related thing. Okay. So pepsinogen 1, pepsinogen 2, including the H. pylori IgG. So this is why the H. pylori comes in a tumor marker, because as you know, this is the H. pylori, Helicobacter pylori goes into the body due to the improper sanitation, and then it goes into the stomach, and this is the only bacteria negative which has tendency acidity of acid environment of the stomach, and in the long term it causes the reflux, and some more acidity cases they can have a impact on stomach's inner wall, and then it may leads to the gastric carcinoma. That's why the H. pylori infection is more susceptible and may leads to in the future to the carcinoma. So you can see here the H. pylori IgG, IgA, and IgM that we have introduced antibodies testings for the suspected patient. And there's a good news that we have a 236 analytes in as of today menu of SNIBE Meglumi platform, and now we have introduced a H. pylori antigen. This is a great breakthrough in terms of serological testing, because the reason is the H. pylori antigen test before that usually on a serological testing there is not available from the chemiluminescence technique. Only the stool sample is required to detect the H. pylori antigen. But due to this in new innovation in the SNIBE assay menu that we have introduced the H. pylori antigen. So I'm more interested in this H. pylori because in the past I have an exposure of H. pylori, and I face all the symptoms of H. pylori, epigastric pain, the continuous acidity, and the reflux esophagitis. And then I took the triple therapy regime, which helps me to reduce it, but it's a very tough bacteria. It may recurrences occurs, so we need to be more vigilant when we are treating the H. pylori infection. Along with that, the tumor markers, we have a gastrin 17, pro-GRP, HE4 for the ovarian cancers, as well as for the breast cancers, and a big PIVKA, especially marker for the liver cirrhosis. So we have a very comprehensive menu for the tumor markers and the other analytes, but we have a more news as well.
А мы можем к Степанченко записаться?
If you talk about the
Гастроэнтеролог.
Snipe
Это я уже,
menu,
блядь, почти
Snipe
год
has
не был.
give
Надо
a
сходить.
comprehensive solution
То все
for
собираюсь. Думаю, да потом, да потом, да потом, да
the
потом.
tumor markers. So the other competitors like Roche, Siemens, Abbott,
Там
Becton,
по-любому занято на ближайшие
they
2
don't have
недели.
this much comprehensive menu for that, because we have a PAP as
Как
well.
раз
We
по
have a
просмотру анализов,
analytes with us, along with the routine analytes that the other competitors they have in their menu. And the big challenge for the Siemens is there is not a one solution from their platforms. So just let me check the chat.
На 6 декабря? Охуенно.
So Anna and Irina, any question?
Заебись.
Okay. So that's why we have a very broad menu, and the biggest challenge for the Siemens platform that the Siemens has not a solution from single instrument platform. For the PAB, they have Emulite. For the CA125, they have Emulite 2K, and for the CA15-3 and CA19-9, they have a solution of Advia Centaur. So the different instrument platform, they have a different instrument for to cover the whole menu of the tumor markers and the other markers, which they have claimed that they have a broad menu. So this is a big challenge. But the Snipe has a big solution for that. And the amazing thing is that all these parameters, reagent, if you have a Maglumi 800 analytes or X3 or X8. So you can run all these analytes on all these instruments. So this is a great innovation that Snipe has done for the tumor marker comprehensive menu. If you talk about more, that we have again the comprehensive solution for that, like CA242. Nobody has this analyte. We have a niche parameters exclusively from the Snipe platforms. We have a Pepsinogeno 1 and Pepsinogeno 2. Only the Abbott has this solution for that. We have H. pylori IgG, IgA, and IgM, along with the H. pylori antigen. Recently, we have launched, and this is a great achievement from the Snipe platform. So we have an unmatched menu. We have a reliable assay performance. And along with that, with the global proficiency testing, we have a more participation, and that's an increasing day by day. So this is a great achievement from the Snipe to acquire the customer satisfaction. If you talk about more assays like Gastrin 17, only the Siemens have this analyte, the Gastrin 17, but from the Emulite platform, not from the Atlica, not from the Centaur platform. They have a solution for the Gastrin 17 from the different platform. If you talk about the total PA, that's only available with the Snipe, and the Herceptin 2 has also available by the Snipe platform. PIVKA is also available with only with the Abbott and Roche, not with the Siemens. So this is why that's why we are a more comprehensive menu for tumor marker as well. So if we talk about the lung cancers, so you can see here, according to the chart incidence and the mortality, which based on the age factors and then age standardization rate according to 100,000 male and 100,000 female incidence versus the mortality. You can see that the most common Carcinoma among that is the lungs cancers that you can see that followed by the prostate in the male, and then colorectals along with the stomach, liver, esophagus, and the bladders. So if we talk about the incidence mortality in the female, the most common carcinoma is the breast cancers, then cervical uterus, colorectums, and then followed by the fourth number is the lungs cancers. So among the men's, lungs is the number one mortality on the basis of the mortality in the men's, according to 2018 data. Lungs is the most common as compared to the women. This is the fourth number is the most common cancers. So if you talk about the lungs cancers, for the lungs cancer, there are different risk factors like smoking. This is one of the leading cause of lungs cancer. Occupational exposures, like even that profession who is exposed to different environmental factors, and the gaseous status where they have a which is dangerous for the occupational. Like for example, if we talk about those people who are working in a leather industry where they are treating the leather or skin of animals with the different chemicals, they have an occupational exposure for the high risk for the lungs cancer. Those people or a medical technologist who are working in a clinical laboratory histopathology section where the formalin utilization is more and they are not taking a preventive action to prevent from the exposure of formalin, that's an exposure occupational exposure for those people, and they have a high risk of lungs cancer and lungs diseases. If you talk about the exercise and physical activities, these are also one of the leading cause. If we are not doing an exercise and physical activity, talk about the diet and food supplement, the tin food, the canned food, and then the food that contains some preservatives, which
Чтобы очень счастливы и
not
довольны.
good for the having an exposure of having a diet and foods exposure of having a uh, carcinoma probability is more. Acquiring lungs disease, the lungs cancer susceptibility genes, that's an inherited, and then air pollution and the alcohol utilization are one of the leading cause of lungs cancers and the risk factor. If we classify the lungs cancers, the histochemistry typings that we can classify the lungs cancer into two types. The one type
Делали ТО, у них фотометр перестал заводить.
NSCLC,
Да.
NSCLC and SCLC. So what is NSCLC and what is SCLC? NSCLC means that a non-small cells lungs cancers. Almost 85% of the lungs cancer. Okay, so 85% of the lungs cancer is divided into two types, which include the squamous cells carcinoma, adenocarcinoma, large cell carcinoma, others. So if we see that on the left side, there is a normal lungs histochemistry. And then if we talk about the 85%, the non-small cells lungs cancer, that's called NSCLC. The number one is then adeno carcinoma, which is among the NSCLC is 35%. This one is the squamous cells carcinoma, which is almost a 30% of the NSCLC. And the adenosquamous cells carcinoma is almost 10%, which is the 10% of the non-small cells lungs cancers. So if we talk about the small cells lungs cancers, it's an estimated a 15% of overall lungs cancer. This type is more aggressive, and then that's you can see that the sarcomatoid carcinoma, large cells carcinoma, and small cells carcinoma, they have a prevalence of 1%, 8%, and 15%, which is more aggressive and more rapidly grows as compared to the NSCLC carcinoma. If we talk about the SNIPE solution, what the SNIPE has given for the rule out of the lungs cancers. So for the lungs cancer, so we have a tribe, TPA, the CEA, SCCA, CIFRA, CA125, NSC, and PRO-GRP. So these are The 7 analyte solution for the lungs cancers rule out for the diagnosis, screening, and the prognosis markers for that. So let's talk about the first CEA. As you know that the CEA stands for the carcinoma embryonic antigen. It's basically a glycoprotein which is primarily associated with the colon tumor and involved in cell adhesion. If you see the immunoelectron microscopy of CEA, you can see that the major pathway of the CEA excretion is here, that you can see that the CEA is releasing from the different pathways. So if you talk about the CEA detection is mainly used for the follow-up visits and the treatment management of the colorectal cancer patient. Around 70 to 90% of them shows a high positive carcinemic embryonic antigen, and also they have an elevated levels have been found in the patient with the rectums, lungs, breast, liver, pancreas, and stomachs and ovary carcinomas. So if the CEA value, if the CEA value abnormally elevated, which is reported in around 30 to 70% of the patient with NSCLC and were most frequently observed in the patient with the adenocarcinoma and advanced stage carcinoma. So it has been reported that in such cases, the elevated CLE reported between 30 to 70% increased value. So this is an specific markers ideally for the management and the follow-up and treatment management for the colorectal patient. So if you talk about the comparison of SNIDE lungs cancer markers as compared to the other. So we have a sandwich method. We have a 2 generation for these analytes, like generation 1 and generation 2. So both are a sandwich principle as compared to the competitors Roche. If we have a calibration interval, we have an improved on-board calibration stability of the reagent. And if we talk about the sample volume, we have an equally good 40 microliter in compare with the 10 microliters. If we talk about the sample types in the 2nd-generation kit, we have a serum and plasma both, but in this 1st-generation, we have only a serum type for the analysis of the patient CEA levels. The edge that we have again in the test per kit, we have a just 50 tests per pack size is also available for the 1st-generation and 2nd-generation CEA, along with the 100 test conventional pack size for that test. We have a concept of limit of blank detection and quantitation, due to which we have an improved linear range as compared to the 1st-generation, while we have an equally good the linearity of compared to the Roche. So if you talk about the diluent included, yes, we have on-board diluent available. If the value exceeding 100 nanogram per ml, we have a possibility of automatic dilution on board, and the dilution, the system will automatically dilute the sample with the on-board diluent. But in case of other competitors, you need to purchase a separate diluent, or you need to make a manual dilution for the high value results. If the test is used for the prognosis, the physician usually refer to the lab for the exact value. So if greater than 1000 nanogram per ml and the physician requests to have exact value to check the prognosis of the disease, they need to be dilute manually on the competitors instrument. As compared to us, we have an automatic privilege on our systems. If we talk about the internal QC, yes, SNIDE is providing a single analyte, 2 levels of free of cost QC, but the competitors, they need a purchase of additional quality control to run on the CEA assay performance verification procedures. So if we compare the carcinemic embryonic acid antigen generation with the commercially available CA markers on the basis of 29 samples. The regression value is 1.00 with the patient value of less than 0.001, which shows that the excellent correlation of our CA second generation with the market available carcinomic embryonic antigen second generation other competitors. So if we talk about the CIFRA 21 and TPA, what is CIFRA 21-1 and TPA? Basically, TPAs stand for the tissue polypeptide antigen. So the cytokeratins are intermediate filament proteins that's found in the cytoskeletons of the epithelial cells. So these are the epithelial cells, and then this CIFRA 21 is the cytokeratin 19 fragment, which is soluble in the serum. So the TPA is degradation product of cytoskeleton formed by the CK8, 18, and 19. So if you want to take a difference for the lungs cancers between this on the basis of the results of CIFRA 21-1 and TPA is that the cytokeratin CK8, CK18, and CK19. If you run these two analytes like CIFRA 21-1 or TPSA SNIPE, you can see that the CK8 is a plus positive, CK18 positive, and CK19 positive. But for the CIFRA 21-1, CK8 negative, CK18 negative, and CK19 case, it only gives you the positive results. So if you want to differentiate the cytokeratin with using this tissue polypeptide antigen and CIFRA 21 assays. So if we talk about the CIFRA 21-1 and TPA, which is the most vulnerable serum tumor marker for the NSCLC, especially for the early diagnosis, observation, and prognosis significance of this squamous cell carcinoma. So if we talk about the lungs cancer, which is associated, categorized on the basis of the stage 1 to 4, according to the severity of the disease, if you can see that here, stage 1, the tumor is localized. Stage 2 start the spreading. Stage 3 is also involve the manifestation and the symptoms, and in stage 4, it is in the metastatic stage. So the moderate elevator in the TPA occurs in some benign events such as liver failure, renal failure, diabetes mellitus, and the pregnancy. But the mark elevated values of TPA is reported in the variety of cancers like lungs, breast, gastrointestinal, urological, gynecological cancers, and other tumors. So if we compare the CIFRA 21-1, we have a competitors, the Roche, as we have a test principle of sandwich, along with the first generation and the second generation of a SNIPE solution for the lungs cancer, rule out them with the competitors. If we talk about the calibration stability, our first generation calibration stability is equally good with the competitor onboard stability, while the second generation has an edge of increased onboard calibration stability of the reagent as compared to the second generation. The sample volume is 20 microliters, which is equally good. The sample type in the second generation is same as that the competitor has. A serum and plasma can be tested for the rule out of the lungs cancer by using the CIFRA 21-1. We have an edge in the pack size of the reagent. We have a very comprehensive LOB, LOD, and LOQ, which helps us to have an optimum linear range, which is 0.8 to 1,000. We have an expected range of less than 3.3. We have a diluent included. Yes, we have a diluent in our system, which gives you the opportunity to give you the exact value for those patients whose prognosis are in process and the doctors or a pathologist want an exact value for the patient that you can perform onboard automatic dilution. So we have a solution for such parameters that we have providing at least 2 level of quality control with the free of cost calibrators to provide and facilitate the customers to run these assays, while the other competitors, they need to buy such analytes, including the QC and calibrator. If you talk about a comparison between the TPA and the CIFRA 21-1, so on the basis of ROC analysis, the pre-treatment diagnosis of respectivity, and then CIFRA 21, and the diagnosis of metastasis stage 4, and then the diagnosis of the pre-treatment tumor stage, including the partial response area under the curve. It is the most of this traditional clinical application that the two serum tests are equivalent because of their virtual identity. The choice between the TPA and the CIFRA can be based on the non-clinical factors, such as the laboratory experience on preference and the cost of the two kits. So they are equally good that the CIFRA and the TPA can be run and then the rule out the different stages of lungs cancers. So if we talk about the TPA specification, yes, we have a sandwich principle equal in both first generation and second generation. But in the second generation, we have an improved calibration interval of from 2 weeks to 28 days. We have a little bit increase in the sample volume just to enhance the assay precision and accuracy as compared to the sample type. They both have a sample type of serum. We have a same package size of 50 to 100 tests, along with the LOB, LOD, LFQ of 3, 6, and 9, which is much improved than the type 1 first generation analytes. If we talk about the linear range, we have an improved linear range defined by the different levels of quantitation. If we talk about the expected range, which is equally good with as compared to the one, and in the second generation of SNIPE total TPA is basically is important because we have a session that we are providing SNIPE second generation kit along with the 2 level of QC and the free of cost calibrators along with that. If you talk about the SCCA, you know that the SCCA is a stand for the squamous cells carcinoma antigen. So the squamous cells carcinoma antigen is basically a TF4. That's the antigen is a group of basically a glycoprotein, which has a molecular weight of 44 kilodalton, and it's basically a tumor markers for the squamous cells carcinoma with good specificity. If this helps to diagnose of all the cancer which is originated from the squamous cells like cervical cancers, lungs cancer, and the head and neck cancers and esophageal cancers. So the SCC antigen is in acidic fractions and neutral fractions increase mainly in the malignant cells. Both the malignant and the non-malignant is squamous cells. So if we compare the SCCA with within the first generation and second generation solution of SNIPE from the Maglumi platform as compared to the competitor Roche, that we have an equally good test principle of sandwich technique along with the calibration enhanced improvement in the 28 days in the second generation and even 4 weeks with the first generation SCCA. So onboard stability is 4 weeks, which is equally good as compared to the competitor. They have offering a 7 weeks onboard stability, but the calibration and stability is less than the SNIPE SCCA calibration. If you talk about the sample volume, we have a competitive sample volume for we have serum and plasma both recommended in the second generation kit as compared to the first generation was only recommended for the serum. If you talk about the test per size, we have an edge in the 50 test, including the 100 test per size, along with the LOB, LOD, and LOQ. We have a very comprehensive, broad linear range in first generation and second generation as compared to the competitors up to the 70 nanogram per ml, but we have an up to 100 nanogram per ml. So the expected range is slightly different from the competitors, and we are providing at least 2 level of QC in the second generation free of cost, the single analytes, while the competitors customers need to be purchased separately the calibrators and control for the SCCA analyte. So any question? Okay. So if you now have any questions, you can ask any question if you want. Okay. So if you talk about the NSE, what is NSE? Basically, it's a neuron specific enolase. It's basically isoenzymes, which is 78 kilodelta gamma homodimers and the respective for the enolase isomer found in the neuronal and neuroendocrine tissues. Basically, it's a level in which a tissue, except the erythrocytes, are negligible. And the biological half-life of NSC in the body fluid is approximately 24 hours. If we talk about the NSC is also frequently overpressed by the neural crest, derived tumors up to the 70 of the patient with the small cells, lungs carcinoma has elevated with the increased NSC levels, approximately with the serum level above the healthy reference range. So it's also a specific marker NSC for the lungs carcinoma, especially the SCLC type small cells lungs carcinoma. So if we compare the NSC with the other competitors, like Roche, we have a test principle of sandwich, which is equally good. So we have a calibration stability much better even in the first generation and second generation as compared to the Roche. They have just a 7 days calibration stability. They have onboard stability is enhanced, but the reagent stability, calibration stability shows that the reagent stability curve is less than the SNIPE NSC second generation and even with the first generation. We have reduced the sample volume and we have a sample type is serum is recommended, which is equally competitive to the other competitors. We have 100 test and 50 test pack size. And along with that, we have a broad measuring range. You can see here, we have 0.25 to 500, and even with the first generation, 1 to 500 nanogram per ml was linearity of our assays. If they goes to the competitor, they have up to 370, higher than 370, they need to dilute it manually rather than to perform an automatic dilution that we have a solution for that. We are providing free of cost 2 level of QC as a single analyte for the NSC from the SNIPE platform, but the other competitors, they want to buy a separate control along with the calibrators to perform that test. If we compare the NSC2 second generation assay with the commercially available NSC using the clinical samples that we have found on the basis of 34 samples. We have a regression value of 1.0, which is an ideally perfect, with the p-value of 0.001, which reflect that our assay has an excellent correlation with the reference assay from the competitors available in the market. So if we talk about the gastrin-releasing peptide, so GRP and the pro-GRP, the pro-gastrin-releasing peptide, is basically an important regulatory molecule which has an express in the human neural systems and then serve as a neurotransmitter that adjusts the body temperature and the central homeostasis. So this is an important regulatory molecule in human neural systems. And the progastrin releasing peptide is basically 125 amino acids pre-pro-protein as the precursors for the 27 amino acid GRP. So this is basically gastrointestinal nerves fiber existing, and then they are releasing in that. So if we talk about the pro-GRP, it's mainly observed elevated values in the gastrointestinal tract, lungs, and neural systems test because the neuroendocrine cells of the fetal lungs has reached that. So if we talk about the pro-GRP comparison, we have a first generation pro-GRP along with the second generation as compared to the competitor Roche pro-GRP. So if you compare the test principle, we have a same sandwich test principle and we have a 1 week calibration interval or reliability of that assay for the 7 days. If we talk about the sample volume, we have 100 microliter as compared to the 30 microliter. We have a sample type of serum and plasma. Both are recommended for the evaluation of pro-GRP in the patient serum. And we have an edge of 50 test pack size in addition with the 100 test pack size, along with the LOB, LOD, and LOQ. You can see that we are equally good in the linearity range of this assay, and then we have a diluent included in our assay that if you want to run an automatic dilution, if the results are higher than 5,000 picogram per ml, then the patient can be reported exactly value with the automatic dilution protocol. So if you have a internal QC requirement, we are providing free of cost at least 2 level of QC for the pro-GRP values and the lot specific values, while the other competitors need to purchase separately. So again, not only the purchase is a challenge with the other competitors, the second thing is an inventory management. Because when you are in laboratory, it's very difficult to maintain the expiries of all these analytes, calibrators and controls, and usually it's very challenging to have a desired expiry of calibrator and controls along with that niche parameters which are launched by the laboratory for the support of patient care, and then the country level screening for the lungs cancers and the treatment of the lungs cancers. So if we talk about the cancer antigen, carcinoma antigen 125. So the cancer antigen is a transmembrane glycoprotein that was first identified in the human ovarian carcinoma cells. And then that the higher CA2 level also found in the 80% patient with the ovarian cancers and the 90% patient with the advanced ovarian cancer. So it can be a differentiate between the epithelial ovarian cancers and then advanced ovarian cancers. And there's also increased level maybe diagnosis. Now, other than cancers, maybe the breast, colorectal, and the lungs cancers. So the CA125 clinical utilization, and that if we compare, we have a 2 generation for CA125, the first generation and the second generation. We have a parallel comparison of these 2 generation along with the competitor Roche CA125. So if we have a 28 days calibration interval as compared to the competitors, which is just a 7 days, which show that the onboard stability of the reagent is not up to the mark. We have a 15 microliter sample volume, and we have a serum and plasma sample type for the evaluation of CA125. We have a 50 pack size. We have a broad measuring range up to the 5,000. We have a 2 level of QC along with that reagent free. So if we talk about the comparison, CA125 comparison with the Roche and Abbott, these are the leading companies who are providing a solution for the tumor markers, that this regression value of 0.97 with Roche and 0.98 with the Abbott shows excellent correlation of our CA125 first generation with the competitors available in the market, and then we have using clinical samples to evaluate this. If we compare the second generation assay of our CA125 on the basis of 73 samples, we have a regression value of 0.99 and the p-value is 0.001 from range from 0 to 4,000 values. That's compared with that, and then you can see that we have an equally good in the second generation, and the regression value is more close to the 1. That's why we have an excellent correlation as compared to the first generation. Both are equally good, but 125 we have an improved sample types and other information in it. If we talk about the lungs cancers, so the role of tumor markers for the early detection of the lungs cancer is if the SCCA value is greater than 2 microgram per liter, then it's probability of 95% of non-squamous cells, lungs carcinoma, or a 5% probability is squamous cells, lungs carcinoma. So if the probability is 95% for the greater than 2 microgram per liter SCCA value, then they have to go for a CEA and CA125. So CEA, CA125 value is greater than 10 or greater than 100. It may lead to the adenocarcinoma or a large cells carcinoma. So if these values are normal and the customers or the patient has referral by the physician for the CIFRA 211 and the CEA combinedly, so then this if they are positive, that means the squamous carcinoma is suspected. If they go for a 5% squamous cells lungs carcinoma, they have to request for the pro-GRP or NSC values. If the pro-GRP and NSC values are elevated, or the pro-GRP values greater than 500 nanogram per liters, then it may lead to the diagnosis towards the squamous cells carcinoma. So this is the clinical utilization of SCCA along with the other lungs tumor markers through which they can differentiate the adenocarcinoma with the large cell carcinoma and the squamous carcinoma and the small cell carcinoma. Any question? Okay. So if we talk about these specific lungs markers like NSC, CEA, CIFRA 21-1, ProGRP, they have some established guidelines from where? National Academy for the Clinical Biochemistry, NACB 2005, and the European Group on Tumor Marker, EGTM 1999. So they have a different application of these lungs marker like NSE. It can be used for the differential diagnosis, right? Yes, for the SCLC. For the prognosis, for the post-operative surveillance, for the monitoring therapy in advanced disease, for detection of recurrent disease. So these are the five clinical application of NSC and SA on the basis of European Group on Tumor Markers and the National Academy of the Clinical Biochemistry. So if we talk about the CEA, we have a differential diagnosis for the prognosis, for the post-operative surveillance and the monitoring therapy in the advanced disease and the detection of recurrent disease, especially in the adenocarcinoma. And for the CIFRA, they have an all in SCLC and SCLC differentiation, and then they have a prognosis, post-operative monitoring and detection of the recurrent disease. With the ProGRP, it's not published yet, but according to the NACP, National Academy of Clinical Biochemistry, ProGRP for the differential diagnosis is for the SCLC, for the post-operative surveillance and the monitoring therapy in advanced disease and the detection of recurrent disease in the SCLC is yes for the clinical application of these assets. So let's go to the part 2, which is breast cancers. So if you want to take a break, we can take a break because we have a start at 1 hour. So you want to take a break? Or we have to take a break after half an hour? What's up to you? Okay, after half an hour, we will take a break. Thank you. So let's start with the breast cancers. So what is breast cancer? As you know that the breast cancer is a cancer that is formed in the cells of the breast. And as you know that the worldwide of breast cancer's distribution is in the countries like you can see here in the Brazil, in the 18 plus age. Out of 100,000 people, how many died from the breast cancers is 18 plus numbers in the Brazil, in the especially in the Middle East countries, and then in some countries have a less ratio of 15 to 17 people died in such countries like in Russian areas. So the tumor size chart is according to that. Is its tumor is 2 centimeter or less than the 2 centimeter size, they call them a T1. If the tumor size is between 2 to 5 centimeters, they call them a T2. And then if this 5 centimeters or bigger, that tumor is called a T3. And any size tumor growing into the chest wall, that's called a T4 tumor. So they have tumors on the basis of tumor size. They classify into a T1, T2, T3, and T4. So if you talk about the breast cancers incidences, in 2017, it was estimated around 252,710 new cases of invasive breast cancers will be diagnosed among the women, and the 2,470 cases will be diagnosed in the men. So these are have a more clinically the incidences in the women as compared to the men as well. Around 3.5 million US women have a history of breast cancers were alive on January 1, 2016. So the breast cancer survival rate, you can see that the stage 0 to stage 1, if it's diagnosed, that's the 5-year relative survival rate for that woman with the stage 0 to stage 1 is close to the 100%. So if we talk about the stage 2 diagnosis and the treatment for the woman with the stage 2 breast cancers, this 5 years survival rate is about 93%. If the woman has an stage 3 diagnosis of a breast cancer, they have a survival rate of around 72%. But often women with these breast cancers can be treated successfully even with the stage 3. If we talk about the metastatic stage, which is a stage 4 for the breast cancers, having a survival rate for about 22%. So the breast cancer that have spread other part of the body are more difficult to treat as compared to tends to have a poorer outlook at the stage 4, but still there are often many treatment options available for the woman with this stage 4 of breast cancers. And the breast cancer is for the most common cancer among affecting women worldwide, approximately 1 million new cases diagnosed every year. So if you talk about the breast cancer's antigen, like 15-3 is basically a transmembrane glycoprotein produced by the MUC1 gene. So this CA15-3 and CA125 can check as an early diagnosis of a recurrent ovarian cancers, the number one. The second point is the CA15-3 is an important indicator for the monitoring of breast cancer patients, especially the cancer or metastasis post-operative patient with the abnormal elevation of 15-3 cancer local or systematic recurrence. In this situation, that cancer antigen 15-3 and 125 can be an early diagnosis. And then CA15-3 together with the CEA testings also improve the sensitivity and specificity for the breast cancers markers. So there is some publication according to the National Academy of Clinical Biochemistry. They have a useful and potential useful marker for the breast cancers. Like if a serum-based marker like CA15-3, they have a post-operative surveillance in patient with no evidence of disease. In clinical use, but value of changing therapy for the patient with rising level not validated in the high levels. So for the monitoring therapy in advanced diseases in clinical use, but value not validated in high level evidence studies. So according to the comparison that CA15-3 comparison, we have a first generation and the second generation along with the competitors, Roche CA15-3, that our test principle is a sandwich principle. We have a calibration interval of 2 weeks, around 28 days, as compared to the 7 days CA15-3 with the competitors, which shows that their onboard reagent stability is compromised. That's why their onboard reagent calibration curve stability is just 7 days. We have a minimal sample volume. We have a both serum and plasma sample type is recommended in second generation, while the first generation was only recommended sample type was a serum. We have a 50 test and 100 test pack size along with the LOB, LOD, and LOQ. So if we talk about LOB, LOD, and LOQ, so do you have any idea about the limit of blank, limit of detection, and limit of quantitation? Hello, everyone. So do you have any idea about this? This is important to clear the concept because the linearity range, you see, is based on the concept of LOB, LOD, and LOQ. Do you have a clear concept about that? Or I will show you a one single slide to explain you more about the LOB, LOD, and LOQ. Okay? So if you want, I can share with you that single slide. Okay. So just give me a time after the break. I will show you the LOB, LOD, and LOQ slide, which helps you to make a more clear concept. Okay. So in this value that you can see that we have a broad measuring range as compared to the competitors. So the very less repeating cost for the CA15 test for not only for the diagnosis tool as well as for the prognosis and the therapy monitoring testing. Expected value, we have a 28 U per ml as compared, we have a diluted onboard dilution activity. We have a 2 level of QC with the free of cost calibrators along with that. So this is about very important for the comparison. We have again the edge of different. If we compare our second generation CA15-3 with the commercially available other competitors in the market for the CA15-3 using the clinical samples of number of samples were 23, the regression value is 0.98. And the p-value is less than 0.001, which shows an excellent correlation with the other competitors available in the market. So what is HER2? So HER2 means human epidermal growth factor receptors 2. So this human epidermal growth factors receptor 2 is basically a 185 kilodelta transmembrane tyrosine kinase receptors. So this is Herceptin 1, Herceptin 2, Herceptin 3, and Herceptin 4. So there are extracellulars and transmembrane and intracellular color diagram for that. The Herceptin 2 gene is basically a proto-oncogene, right? Is this Herceptin 2 gene is located on the chromosome 17p11.2-12. So basically, the member of this Herceptin gene family, which include Herceptin 1, 3, and 4. And then this is an extracellular domain and the single transmembrane lipophilic domain. You can see that this cell membrane, this is cytoplasm with the tyrosine kinase activities, receptors, and the extracellular domain and ligand binding site. So there's intracellular tyrosine kinase domain. Then this ECDA can be shed from the cell surface and released into the bloodstream. So what are the guidelines for Herceptin 2 assay for the breast cancer evaluation according to the National Comprehensive Cancers Network guidelines version 2018, invasive breast cancers Herceptin testing by the validated IHC assays. So they have a different evaluation and the clinical pictures with the Herceptin 2 testing by validating single probe IHC assay, Herceptin 2 testing by the validating dual probe IHC assays. So according to this guideline, they have reflects with the ISH assays, and then these ISH assays has a clinical utilization for different condition in that they can perform it, and then they can rule out the breast cancers. So Herceptin 2, again, it's an excellent correlation with the Siemens. You can see here that we are using a sandwich technique, which is an ABI. As compared to Acridanium esters, we have an equally good sample volume along with the serum and plasma. We have an edge versus the Siemens Herceptin 2. They are using only a serum type for that. If we talk about the calibration interval, we have just 7 days, which is slightly lower than the Siemens. If you talk about the LOB, LOD, and LOQ, we have a broad measuring range of between 2 to 350, and then we have automatic dilution option available because we have a diluent included in the reagent pack when they put it on the onboard. You just need to click the automatic dilution button if you required dilution if the values are higher than 350 nanogram per ml. Along with that, we have a solution of quality control and calibrators with the reagent free of cost. 2 level of QCs are available, while the other competitors need to buy it separately. So if you want to go for a comparison with the Herceptin 2 first generation SNI Meglumi versus the commercially available Herceptins, around 135 samples were choose between the range of 4.8 to 342 on Herceptin's 2 assay and a commercially available immunoassay. The data resulting show the linear regression of 0.988, and which is a very excellent correlation of our assay with the commercially available assays. If you talk about the ovarian cancers, as you know that the ovarian cancer is the uncontrolled growth of a cells within the woman ovary, and 3 types of tumors are seen. That's maybe some epithelial tumor, that's the majority of ovarian tumors, or a germ cells tumors, less than 2% of all the ovarian tumors, and the stromatal tumors, which are about 1% of all the tumors. So you can see, if you see the structures of the female reproductive systems, that there's an ovaries, and then the ovaries have the fallopian tubes, and they are connecting to the uterus and the cervix and upper vaginal areas. And then if you goes to the further inside the ovaries, and then you can see that the ovaries has an germ cells, which may lead to the germ cells tumors, and they have epithelial cells, epithelial layers. They may produce an epithelial cells tumors. They have mature follicles and the stroma cells, and then they may lead to the stromal cells tumors. So if we talk about the epidemiology of the ovarian cancers, that an estimated age standardized incidence rate according to that, the North American side, I have the worldwide distribution is a 8.1% higher in the Russia, in the European countries, along with the some prevalence in Australia, and then the Middle East countries. So this is an overall prevalence of epidemiological distribution of ovarian cancers globally. If we talk about the diagnosis of the ovarian cancers, you can see according to the guidelines of the American College of Obstetrics and Gynecology, ACOG, in 2002. Excuse me. So we have an oncologist mainly rely on the menopausal status, which is in a pre-menopausal if the women are less than 50 years of age, and they have a 1 to 5 greater than 200 U per ml. They have some ascites, abdominal or a distal transfers, family history of breast and ovarian cancers in a first degree relatives. So the post-menopausal cases in which the 50 years or a greater than 50 years old woman, if they have a CA125 value is greater than 35 U per ml, and they have ascites and small noodles or a fixed pelvis mass, abdominal or distal transfer to UV, and the family histories of breast and ovarian cancers in the first degree relatives. So for the ovarian cancers, the cancer antigen is highly specific, is 72.4. At the 72-4 means the tumor associated, it's basically a glycoprotein, TAG72, and found in the surface of the many cancer cells, including the ovary, breast, colon, and pancreatic cells. So this cancer antigen is basically antigenic determinant is located in the TAG72, and the CA72-4 and CA125 test are a marker for the diagnosis of primary and recurrent ovarian tumors. So the CA72-4 and 125 are most reliable marker for the ovarian tumors, and these are the jointly applied in the detection of as well as for the gastric cancer, that's in CA72-4 and CA19-9. So the combination of CA72-4 with CA125 and CA19-9 can help to differentiate ovarian tumor primary diagnosis or recurrent along with the detection of gastric cancers. If you talk about the CA72-4, that's an test principle of the sandwich technique. If we talk about some 28 days on calibration stability in the second generation, the first generation has 2 weeks onboard stability, calibration stability. If you talk about the onboard reagent stability, we have 1 month. They have a 2 months onboard stability. Sample volume is 40 microliters, which is equally good. And then sample time, serum and plasma, both are recommended. If you talk about the pack size, we have an edge in the pack size. We have an edge and free of cost. QC and calibrators with the broad measuring range of 500 up to as compared to the 300 U per ml in the Roche cases. Any question? Okay. So if we compare with the reference instrument assay, CA72-4 second generation assay has a commercially available with the SNIDE Meglumi 72-4 using the clinical samples number is 37. We have a regression value of 0.96 with a p-value of less than 0.001, which shows an excellent correlation of our assay with the commercially available CA72-4 analyte is available. So this is most important that in performance-wise, our assays are equally good as compared to the other competitors in the market. So the pancreatic cancers. So what is a pancreatic cancers? The pancreas is it's a gland which is located behind the stomach and in front of the spine. So if you see here, this is stomach, and this is basically a pancreatic duct. And then this is pancreas. So basically is in front of the spine, and this pancreas produce digestive juices and hormones that regulate blood sugar. So if we talk about more the pancreatic cancers has a very few early signs. Then these pancreas are located deep in the abdominal. So a tumor in its early stage cannot be felt on a physical examination, but its early symptoms occur. They are very journal and vague and can be caused by the many conditions other than pancreatic cancers. So what are the pancreatic cancers? Some symptoms like back pain, maybe jaundice, dark urine and light stool, maybe some nausea. They have unwanted weight loss. They have a pain after eating. They have loss of appetite. They have a lower abdominal pain, upper abdominal pain, and maybe some sort of that pain. So the two main types of pancreatic cancers, one is called exocrine adenocarcinoma, which is the most common type of far, and the pancreatic neuroendocrine tumors, which is almost a rare tumor in that. So if we talk about the pancreatic cancers global distribution, according to the WHO, International Agency for Research on Cancers, the pancreatic carcinoma estimated age standardized incidence global rate in 2018 for the both sexes and ages depends upon that the European countries, they have a more prevalence in the American region, and then the Brazil region, South American regions have a more prevalence of that, including the Australia. They have a greater than 7.2 per 100,000 people. And in some countries, they have no data for that. That's why they have some gray and fawn colors in that. So if we talk about some cancer antigen, which is a CA19-9. The cancer antigen CA19-9 is basically a mucin glycoprotein, which is primarily being found in the serum of the patient with the colon cancers and the pancreatic cancers. So it is basically expressed on the surface of cancer cells and elevated with the 19-9 as an MA problem. So the elevated CA19-9 in the cancers or a benign disease, they may have some pancreas and acute cholangitis or a biliary cancers, gallbladders, colonangiocarcinoma, ampullary, hepatocellulars, gastrics, ovarian, colorectals, and lungs, breast, and uterus. So this elevated CA19-9 maybe occurs in the cirrhosis and other cholestatic diseases. So if we talk about the highlighted articles in that, the tumor markers in the pancreatic cancers market, according to 2013, they have an annual meeting in the Chicago. They have a key message for that, the baseline, the first course of the salvage chemotherapy, the baseline CA19-9. And then the second course, they have to check the CA19-9 increase by the greater than 17.8%. And the progression-free survival rate is 2.6% a month, and the overall survival is 1 month. So the preoperative 19-9 levels correlate with the cancer stage and hence can indirectly be used as a marker for the tumor respectively. So if we talk about the 19-9 levels that are used adjacent to the guide, further management determine prognosis in the patient as well for that. So if we talk about the comparison of SNIPE CA19-9 assay of first generation and the second generation versus the competitor Roche 19-9. So we have a test principle based on a sandwich technique, and the calibration interval is the 2 weeks and the 7 days. So we are comparatively better calibration stability on SNIPE platform for the CA19-9 as compared to the competitors. We have a optimum sample volume, and the sample type is equally good as compared to the competitor, with the low test kit pack size, which is more convenient for the end users, with the limit of blank, limit of detection, limit of quantitation concept, with the linear range of 0.9 to 1000, which is equally good as compared to the competitors. If we have a dilution required more than 100,000, more than 1000 U per ml value, if they, for the prognosis purpose, they need to give an exact value so they can dilute automatically. The automatic dilution protocol is available, and then they can run the dilution automatically. We talk about the 2-level of QC. We are providing solutions for the 2-level of QC. They can run more than they can run free of cost different ranges. And other than that, if the customers are using different carcinoma markers, they don't want to use high free of cost quality control. They can use a third party QC like Recast and ICAS. They are offering a multi-analyte quality control for that. So if you are using multi-analyte cancers markers and they don't want to use a single analyte, they can use a third party which are available in that. While that the Ross, they have a different strategy. They need to purchase, if the customer wants to run that analyte, they need to purchase separate calibrated control for that analyte.
Внутри карусели это что пизда? А если он не перевернуть, ничего нельзя?
So if we compare the CA 19-9 second generation with the commercially available 19-9, we have seen that from the lower value to the higher value, they have on the basis of 32 different clinically available samples to get the excellent correlation of regression value of 0.98 with the patient values of p-value of less than 0.001. So if we talk about the cancer antigen, that's in 50. The cancer antigen CA50 is basically a sialic acid, that's a glycoprotein which is absent in the normal tissues, but when cells becomes cancerous or glycosylase is activated to form a CA50 by changing the structure of surface antigen. And then this is a non-specific tumor markers of the broad spectrum, which is distributed in the tumor tissues of colon, rectum, stomach, jejunum, ileum, lungs, pancreas, gallbladder, bladder, uterus, and livers. So if the elevated CA50 can also be observed in some benign diseases that such as ulcerative colitis, cirrhosis of the livers, pneumonia, nephritis, and pancreatitis as well also increase the CA50 markers. So the CA50 gives a fairly similar results to the CA19-9 as a little diagnostic value, but is very useful for the monitoring of pancreas patient with the pancreatic carcinoma. So this is very much important marker for highly to differentiate the cancer antigen CA50 for the pancreatic carcinoma. So if you want to talk about some diagnostic tools for the pancreatic tumor markers, along with the CA19-9 marker and CA50 markers. So according to this sensitivity and specificity, they have some correlation with that. And then the conclusion is that the CA50 binding is a serum has a specificity and sensitivity which is compatible to the 19-9, and with this combination of these tumor markers they can help us to rule out the pancreatic carcinoma. So the sensitivity and specificity is an excellent value for the diagnosis of pancreatic tumor. So if we compare with the pancreatic cancers of CA15 NASH with the test principle of a sandwich and then calibration interval of 2 weeks, the second generation has almost a 1 month, 28 days. We have a minimal sample volume in the second generation as compared to the first generation. We have a serum and plasma, both sample type validated on the second generation of CA50 as compared to the first generation. We have a 50 and 100 pack size. And along with that, we have an improved linear range in the second generation as compared to the first generation. We have a diluent on board if in case of this marker CA50 for the pancreatic carcinoma prognosis after the diagnosis tool, they can use as an automatic dilution to provide an exact result if the patient value is exceeding 500 U per ml. We are providing in a second generation 2 level of QC free of cost for the monitoring of the assay reliability and the performance on the systems. So you want to take a break? We can take a break. So we can start with the CA24-2. Okay.